going to discuss about case-based learning, initiation and intensification with insulin regulated as part. This is my financial disclosure. Today agenda is divided into two parts. Part 1 is initiation with insulin regulated as part and part 2 is intensification with insulin regulated as part. Here is the first case. Mr. Abhishek, 58 years old, male, working as a lecturer. His medical history is he has type 2 diabetes mellitus since 2010, that is more than 13 years of duration, and he has dyslipidemia since 2016, and he is on tablet glimepiride 2 mg Ryzodeg and metformin 1000 mg Ryzodeg and tablet dapagliflozin 10 mg once a day. And other concomitant medications are tablet aspirin 75 mg once a day and tablet atorvastatin 10 mg once a day. And his blood reports are fasting plasma glucose is 178 mg per deciliter and postprandial glucose is 302 mg per deciliter. His HbA1c, that is glycosylated hemoglobin, is 10.2% and his serum creatinine is 0.8 mg per deciliter. Serum cholesterol is 234 mg per deciliter. LDL is 102 mg per deciliter. Serum triglycerides are 174 mg per deciliter. So on the whole, Mr. Abhishek has long duration of diabetes, more than 13 years, with concomitant comorbidities like dyslipidemia. Both are uncontrolled, blood sugars and cholesterol. And what to do? Mr. Abhishek, 58 years old, clinical challenge, uncontrolled glycemic parameters. How do we manage? The basic funda is when the patient is on 3 oral anti-diabetic drugs with uncontrolled blood sugars, the next drug to add is to start insulin to get good glycemic control. Because in type 2 diabetes mellitus, by the time of diagnosis, more than 50% of beta cells, functioning beta cells, were dead. Every year there is loss of 2% of functioning beta cells. Adding other drugs and increasing the rows of drugs will not fetch in any way and leads to insulin bankruptcy. So it is best to start insulin. There are few options we'll discuss. By increase the dose of glimepiride and alternate SGLT2 inhibitors, there is no use. By shifting from dapagliflozin to empagliflozin or canagliflozin, there is no much difference. And adding DPP4 inhibitors is a weak anti-diabetic drug, and adding GLP-1 receptor agonists. In this case, my choice is to start insulin. What guidelines recommend? RST clinical practice recommendations for the management of type 2 diabetes mellitus 2022. Insulin therapy should be considered in all patients failing to achieve glycemic targets on 3 oral agents. Insulin regulated as part a coformulation is a preferred choice at insulin initiation. RST clinical practice recommendations for management of type 2 diabetes mellitus 2022. Ryzodeg15 is recommended as a choice for insulin initiation. Ryzodeg15 causes the least hypoglycemia, requires fewer dose, causes the least weight gain, has the flexibility of administration before any large meal of the day, and can be given with different meals on different days. Because hypoglycemia plays a very important role in causing sudden cardiac death by causing cardiac arrhythmias and cardiac arrest. So, because it is considered as a pro-atherosclerotic factor by activating the sympathoadrenal activation and increasing the counter-regulatory hormones. So, the hypoglycemias are not welcome nowadays. So, this Ryzodeg causes least hypoglycemia So we recommend Ryzodeg as a choice for insulin initiation. Ryzodeg causes lower hypoglycemia, fewer dose requirement, and flexibility of administration. This is a case study for 26 weeks on insulin naive patients with type 2 diabetes mellitus. 296 patients were selected. On one arm, 147 patients were put on Ryzodeg once a day along with existing OADs, and 149 patients were put on insulin glargine U100 along with existing OADs. So this study shows the difference between the efficacy and safety between the insulin regulated aspart and IGLAR U100. The significantly better postprandial glucose control after major meal is seen with the insulin regulated aspart because it contains 70% of basal insulin degradate, which efficiently controls the postprandial glucose spikes after a major carbohydrate meal, which will not be done with the insulin glargine. And there is a superior glycosylated hemoglobin reduction, that is HbA1c reduction more than 1.4% is seen with the insulin regulated aspart when compared with the insulin glargine U100. And the similar fasting plasma glucose control is seen with both Ryzodeg and IGLAR U100 because insulin regulated aspart contains 70% basal component of insulin regulated, so it maintains the fasting plasma glucose. The Ryzodeg provided superior long-term glycemic control compared to IGLAR U100 with lower risk of hypoglycemia. With Ryzodeg, 72% more patients achieved their targets without experiencing hypoglycemia than once a day insulin glargine U100. This is from IDF Congress 2019 held at Busan. Insulin initiation in OAD failure patients with type 2 diabetes mellitus. Can Ryzodeg write a new script for the subcontinent? Yes. The left side graph shows insulin glargine U100 is represented as dark blue, IGLAR U300 as light blue, Ryzodeg is green color. The baseline HbA1cs are 9.61 with insulin glargine U100 and 9.12 with insulin glargine U300 and 9.61 is the baseline A1C with insulin regulated aspart. And at the end of the follow, the decrease of HbA1c with insulin glargine U100 is from 9.61 to 8.56, clearly seen in the graph. And with the insulin glargine U300, the baseline HbA1c 9.12, there is reduction of HbA1c to 8.34. And with Ryzodeg, there is more reduction of HbA1c from 9.61 to 8.09 compared with the others. And on the right side graph shows the percentage change in the glycemic parameters. Here dark blue bars represents Ryzodeg and light blue represents the insulin glargine U100 and green represents the IGLAR U300. There is first one is the fasting plasma glucose. There is a decrease of 34.63% of fasting plasma glucose is seen with the Ryzodeg, 32.9 with insulin glargine U100 and 26.72 with insulin glargine U300. And coming to the postprandial glucose, 28.63 with Ryzodeg, 19.29 with IGLAR U100 and 19.71 with IGLAR U300. And coming to the HbA1c, the reduction is in 15.81 and 10.76, 8.55. The ideal gas caused significantly greater reduction in HbA1c, fasting plasma glucose, postprandial glucose versus Iglar U300. So, insulin initiation in VAD failures in patients with T2DM. The left side graph shows the baseline and the follow-up periods, the insulin requirement. The insulin glargine at the baseline 13.44 units is the dose. At the follow-up, it is increased to 24.1 units. And coming to the insulin glargine U300, baseline 20.2 and follow-up 25.61 units. And coming to the idagast, the baseline 11.23 and the follow-up 14.41. So, significant increase in insulin dose requirement is seen in insulin glargine U100 arm. The non-significant increase is seen with Iglar U300 and the idagast arms. And coming to the right side graph, proportion of patients reporting hypoglycemia. So, first graph shows the insulin glargine U100. There is 22% of patients showed hypoglycemia. With Iglar U300, 11.11% shows 11% shows hypoglycemia. With idagast, 17.97% showed hypoglycemia. So there is no significant difference in hypoglycemia occurrence between these groups. So time to treatment intensification. Idagast versus Iglar U100. Time to treatment intensification. The time between index date, that is date on which HbA1c is more than 7% on existing therapy, and the first prescription for the additional anti-hyperglycemic agent or the dose intensification during the follow-up period. So, the comparing time to intensification between insulin dendritic aspart per insulin aspart and insulin glargine. This is a single center experience from the India. The time needed to treatment intensification between the two groups are seen in this graph. So 11.65% intensified in the idagast group and 11.98 plus or minus 7.81 months needed to intensify the dose with the idagast. So coming to the Iglar U100 group, 17.34% subjects intensified in this group and 6.71 plus or minus 6.86 months with Iglar U100. This shows the longer duration is needed to intensify the dose with the idagast when compared with the Iglar U100. So significantly fewer subjects on idagast required dose intensification, and additionally the time to treatment intensification was significantly longer in subjects on idagast as compared to Iglar U100. So switching to idagast from glargine U100 or U300. So this graph shows insulin dose. So the gray color shows the baseline and the green color shows the end of the study, the color bars. So at the baseline the total dose of insulin requirement is more or less same. At the basal dose there is estimated change, and prandial there is no much difference. So significant reductions in basal and total daily insulin dose with the idagast after 26 weeks. So diabetes therapy related quality of life. The total diabetes therapy quality of life scores. At the baseline there is 67.3% have quality of life, and at the end of the study 70.6% had quality of life. So there is significant improvement in total diabetic therapy related quality of life score with idagast in patients with HbA1c more than 7%. So what is the treatment preference? So 74.2% preferred Idagasp to their previous treatment. So switching to Idagasp is associated with a total and basal insulin dose requirement and significant improvement in quality of life. So impact on quality of life and treatment preference. This is a single center survey. Adult T2DM treated with Idagasp 20 by 26 questions in 245 patients. This shows 94.2% managed their day-to-day activities better after Idagasp initiation, and 89.8% had improved quality of life with reduction in number of treks, and 86.7% found it comfortable to inject Idagasp in different social situations. So there is a flexibility, safety and efficacy is seen with the Idagasp. Reduction in number of injection pricks, flexibility, simplicity of dosing with Idagasp translates into better quality of life. So reduction in pill burden. So reduction in pill burden with Idagasp initiation is seen in 70% of patients on 3 OADs could be shifted to 1 or 2 OADs, and 50% on 2 OADs a day were shifted to 1 OAD a day. So this reduces the pill burden on the patient. So reduction in the pill burden with Idagasp initiation, the percentage of individuals with lower pill burden 13% on 2 OADs and 47% on 3 OADs and 17% on 4 OADs. So reduced pill burden improves the quality of life and adherence to treatment in individuals with diabetes. So coming to our case, Mr. Abhishek, 58 years old, male lecturer. The treatment option is dapagliflozin 10 mg OD will continue, metformin 1000 mg BD continued, and glimepiride discontinued, and injection Ryzodeg 10 units before the dinner, which is the largest meal for him. So counseled on diet and lifestyle modification has done, and emphasized the need for routine self-monitoring of blood glucose, that is SMBG, and optimal titration is required, and educated on symptoms of hypoglycemia and need for intervention. So a brief counseling on the hypoglycemia and how to contract it should be counseled to the patient. So what are the practical recommendations? So Idagasp should be administered with major meal of the day. Either it is breakfast or lunch or dinner decided by the patient words, or by taking the SMBG readings will decide and will start the Idagasp once a day with 10 units with the most carbohydrate heavy meal of the day. So what are the practical recommendations? Weekly titration using a simple algorithm. If the fasting plasma glucose target is more, so we'll increment the dose by 2 units. If fasting plasma glucose is a target, so maintain the same dose of insulin. If it is below the target, reduce the dose by 2 units. So once a day Idagasp dose with major meal, and what to be considered for titration is fasting plasma glucose. This has to be taken by lowest or mean of 3 recent SMBG values. We decided and we will adjust the dose. And BID Idagasp dose with pre-breakfast or pre-lunch, the blood glucose considered for titration is pre-dinner, and pre-dinner Idagasp dose is decided by fasting plasma glucose levels. So this case, we initiate the insulin at bedtime with dinner. The is initiated with 10 units of Idagasp. The fasting plasma glucose is At baseline is 178 milligrams per deciliter, postprandial glucose is 302 milligrams per deciliter, HbA1c is 10.2 percent, and weight is 72 kilograms. After 1 month, the insulin dose is titrated to 14 units. At fasting plasma glucose has come down to 162 milligrams per deciliter, and postprandial glucose is 268, and weight remains same. And after second month, the dose titrated to 18 units, and fasting plasma glucose is 142, and postprandial glucose is 242. Weight remained the same, 73 kilocalories. After fourth month, dose titrated to 20 units, and fasting plasma glucose is 108, and postprandial glucose is 162, and HbA1c is 7.6 after 16 weeks, and weight is 72. So there are no documented episodes of hypoglycemia are reported. So coming to the second part of our agenda, intensification with IDEC asp. So here is another case. Mr. Vinod, 52 years old man, he is working as a bank manager. Duration of diabetes is more than 14 years, and his BMI is 25 kilograms per square meter square, and he has recurrent hypoglycemia, and he needs surgery for cataract. So has long duration of diabetes, overweight, and recurrent hypoglycemic attacks, and he needs surgery for cataract, and he is on Limiprid 4 mg twice a day and tablet Oglibos 0.3 milligrams twice a day, and insulin glargine 40 units before breakfast, up titrated to current dose over 8 months. Still, the blood sugars are not up to the mark. His fasting blood glucose is 178 milligrams per deciliter, and 2 hours postprandial glucose is 285 milligrams per deciliter, and his HbA1c is 9.6, terribly out of control, and serum creatinine is 1.5 milligrams per deciliter, and his estimated glomerular filtration rate is 56 ml per minute per 1.73 meters square. So the patient has long duration of diabetes, overweight, and recurrent hypoglycemia with diabetic kidney disease, stage 3A, and recurrent hypoglycemias with recurrent hypoglycemias. So the clinical challenges are uncontrolled glycemic parameters and recurrent hypoglycemia and renal dysfunction and need for cataract surgery. And how do we manage this? Up titrate the insulin glargine. There is no use after 40 units. Already he reached the 40 units maximum dose. He is using 40 units of insulin glargine. By up titrating the dose, the sugars may not be controlled, so it's of no use. Administer glargine twice daily, it will not fetch him. And shifting to premix insulin once a day or twice a day, okay, it will control the blood sugars, but he has problem is recurrent hypoglycemias. The hypoglycemic incidences are more with premix insulins when compared with the insulin degdec aspart. And shift to basal plus, so it has to be titrated with basal insulin degludec, and with prandial insulins, and 1 shot or 2 shot or 3 shots required, depends on the glucose levels. So it's a cumbersome procedure. And shifting to the Ryzodeg once a day or twice a day, in my choice is shifting to Ryzodeg once a day and twice a day, which is simple and which is easier for the patient to administer, and maintaining the blood sugars. So coming to the Vinod, Mr. Vinod, we stopped the insulin glargine and glimepiride. So we initiated the insulin Ryzodeg 20 units in the morning and 20 units with dinner, 20 units with the morning breakfast and 20 units with the dinner. And we added tablet linagliptin, which is a renal gliptin for the renal safety, because he has diabetic kidney disease. It's the best option to start the linagliptin 5 milligrams once a day. And in my opinion, I also add DAPA SGLT2 inhibitors, because his eGFR is more than 54. To preserve the kidney function, we can add either dapagliflozin or empagliflozin to preserve the kidney function, to protect the kidney function, and from to give the cardiac protection also. So, and the dosage is titrated to 24 units in the morning and 18 units over in the night over 4 weeks. So, balanced review. What are the pros and cons of this? Address the postprandial glucose excursion. Yes. Once daily dose may be sufficient. No. Intensification can be done with the same pen, because it can be given once a day or twice a day, and robust data is available. What are the cons? Is there stopping effect if given before the breakfast or before lunch? No. What is the stacking effect? Repeated doses of rapid acting insulin may lead to abnormal low blood sugars that causes the insulin stacking. So it is not seen with the iodic acid. So switching to iodic acid from basal insulin. Switching from basal insulin is recommended if glycemia is insufficiently controlled, or 36 to 40 units or 0.5 units per kg per day of basal insulin is reached. That is maximum dose. So then it's a high time to shift from basal insulin to this coformulation. And unit to unit conversion when switching from basal insulin. Reduce the dose for those experiencing hypoglycemia or previously on insulin glargine 300 units per ml. So, when to stop titrating basal insulin and consider prandial control options. So, the individual is not meeting the glycemic targets on basal insulins, then it is high time to shift from basal insulin to other insulins. The HbA1c still not at goal with 0.5 units per kg per day of daily basal insulin. And second one is HbA1c elevated despite normal fasting plasma glucose with basal insulin. And third one is fasting plasma glucose with basal insulin is within the targeted range, but postprandial glucose is persistently above the goal. So normal basal insulins like insulin glargine or other basal insulins, they could not maintain the postprandial excursions as effectively as insulin dendritic aspart, because there is reduction of postprandial glucose spikes is seen with the insulin dendritic aspart but not with other basal insulins. Further increase in basal insulin result in hypoglycemia. If you go on increasing the dose of basal insulin more than 40 units, it may result in hypoglycemia. So other options for intensifying the basal insulins. So basal insulin once daily, increase the dose or frequency, or when the adding oral agents and adding DP4 inhibitors, adding GLP-1 receptor agonists, adding SGLT2 inhibitors, adding prandial insulins. So see this graph, the intensification journey. Here there are two beautiful diagrams. So one is Mr. Amar and one is Mr. Prakash. Two journeys. By seeing the picture, we can say Mr. Amar has a beautiful journey, simple journey, because he is on OADs, uncontrolled diabetes. You initiated ida gas once a day. When the blood sugars are not up to the mark, we intensified to twice a day. So with one pen and two pricks, he achieved the glycemia. So simple. And coming to the Mr. Prakash, who is on multiple OADs, and we added basal insulin, one injection. So blood sugars are not up to the mark, so we added one prandial insulin along with the one basal insulin. That makes 2 injections, and we incremented to one basal insulin and one aspart injection aspart twice a day, 3 injections, and basal insulin plus insulin aspart thrice a day. That is 3 prandial doses, making put together 4 injections, which becomes cumbersome, hectic for the patient, and sometimes they forget to take the insulin, they miss the dose. So it is cumbersome for the patient. So intensification from basal to basal plus, that is basal plus insulin aspart to basal bolus therapy, that is 3 prandial doses of insulin aspart plus basal insulin, is seen in this case. So we can decide which is easier, which is safe, and which is convenient. So Idegas versus basal plus therapy. So there is a study conducted over the period of 38 weeks. The patients with type 2 diabetes uncontrolled on basal insulin, 532 people are selected, and on one arm 267 patients were put on insulin degludec aspart once a day along with existing OADs, and 265 patients were put on insulin glargine U100 once a day with insulin aspart once a day, as it is basal plus, along with existing OADs. For up to the 26 weeks, there is no intensification. After 26 weeks, intensification was done. Insulin degludec aspart it's from once a day to twice a day. It's so simple. In the basal plus arm, the insulin glargine U100 once a day, we incremented the insulin aspart from once a day to twice a day to thrice a day, along with existing OADs at the end of the study. So see the graphs. The grey color, the dark brown color represents the basal plus, and the blue color represents the insulin degludec aspart. So there is the dose of insulin degludec aspart is low when compared with the basal plus therapy. So there is significantly 12% of significantly lesser dose requirement is seen with the insulin degludec aspart group when compared with the basal plus group. And the second graph shows the nocturnal hypos in Idegas group and IGLAR and plus IAS group. With the basal plus group, there is increasing the dose of insulin is required, along with the increasing risk of nocturnal hypos is seen. After 26 weeks of treatment with the Idegas group, there is significantly reduction of the nocturnal hypoglycemia, that is 45% reduction is seen. So nocturnal hypos are very much less with the Idegas group. At the end of the study, 38 weeks, the still low, only 39% risk is seen with the Idegas group. So Idegas versus basal bolus therapy. So lower dose and fewer injections. Same, patients with type 2 diabetes, 532 number are selected, uncontrolled on basal insulin. On one arm, 267 patients, Idegas once a day along with existing OADs, and 265 patients, IGLAR U100 once a day along with the IAS once a day along with existing OADs. And the study period is same, 38 weeks. After 26 weeks, intensification was done. Idegas to once a day to twice a day, and Iglar U100 once a day and along with IASP once a day to twice a day or thrice a day along with the existing OADs. So Iodine achieved similar improvement in fasting plasma glucose and glycosylated hemoglobin compared to basal bolus therapy. 6.6% significantly lower dose with Iodine versus insulin glargine U100 plus insulin aspart at the end of the study, and fewer mean number of daily injections with Iodine 1.6 versus insulin glargine U100 plus insulin aspart 2.9. So what are the perioperative recommendations for insulin deglutic aspart? The perioperative recommendations of insulin deglutic aspart are for the minor procedures like cataract surgery. The patient is able to eat normally, so there is no need to reduce the dose. We should continue the same usual dose. And instances of prolonged fasting required such a procedures like colonoscopy, the dose should be reduced to 30 to 50% approximately 3 days before the procedure. In the case of major surgery, the Iodine should be discontinued because it has long acting basal insulin. Coming to the insulin deglutic in renal impairment, the green color shows normal, light green, and dark green is mild impairment of renal function, and orange color shows the moderate impairment of renal function, and red color shows severe impairment of renal function for the period of 24 hours since the injection, and the deglutic concentration is seen, but the pharmacokinetic properties of insulin deglutic are not affected by varying degrees of impaired renal function. So it is safe to use in all renal parameters are renal dysfunction and hepatic dysfunction. It is safe. This insulin is safe. So the deglutic in renal dysfunction, according to the Indian data, here there is comparison between the insulin glargine U100 and the insulin deglutic U100. What studies and p-values are given in this graph tables. The stage 3B diabetic kidney disease, the overall hypoglycemia is seen in the insulin glargine U100 or 10, with insulin deglutic U100 only 5. So less number of cases are seen, hypoglycemia are seen in deglutic arm, and documented mild hypoglycemia 6 cases are seen with Iglar U100, only 5 with Idec U100, and documented severe hypoglycemia, only 2 cases are reported with Iglar U100. There is no case reported with Idec U100. And coming to the nocturnal hypoglycemia, only 2 cases are reported with Iglar U100. There is no case reported with Idec U100. The p-value is 0.046, which is significant. And coming to the stage for CKD, overall hypoglycemia are 26 in case with insulin glargine U100 and 9 with insulin deglutic U100. Documented mild hypoglycemia are 14 with insulin glargine U100, 8 with insulin deglutic U100. Documented severe hypoglycemia in stage 4 DKD is only 6 cases are seen in Iglar U100, only 1 case with Idec U100. Nocturnal hypoglycemia 6 cases with Iglar U100, no case of severe nocturnal hypoglycemia is seen with Idec U100. This shows in advanced renal failure also Idec cause statistically significant less hypoglycemia than Iglar U100. So no significant association between the estimated glomerular filtration rate and the requirements of the insulin aspart. So this graph shows bar diagram. The red color shows the estimated glomerular filtration rate less than 60 ml per minute, and yellow shows eGFR 60 to 80 ml per minute, and green color shows eGFR more than 90 ml per minute. And the first one is the mean daily doses of insulin Respro, insulin aspart, and short-acting human insulin units per kg body weight per day in relation to the estimated glomerular filtration rate is seen with this case. Insulin requirements in 346 patients in T1DM assessed in an observational study. The requirements of the insulin aspart did not show any association with the eGFR. The insulin aspart was associated with less variability of dose requirement. So coming to our case, Mr. Winner, 52 years old, we started the Ida gas with the 14 units in the morning and 14 units in the bedtime. At that time, fasting plasma glucose is 178 milligrams per deciliter, postprandial glucose is 285 milligrams per deciliter, his HbA1c is 9.6, his weight is 72 kilograms. After 1 month, we increased to 18 units in the morning and 16 units in the night. Fasting plasma glucose is 136 and postprandial glucose is 206. HbA1c is not recorded. Weight is 72 kilograms per second. The insulin dose is titrated to 22 in the morning, 18 units in the night. Fasting plasma glucose has reached the target 107 milligrams per deciliter. Postprandial glucose is 192 milligrams per deciliter. After third week, the insulin dose is 24 units in the morning, 18 units in the night, and fasting plasma glucose is 97 milligrams per deciliter. Postprandial glucose is 161 milligrams per deciliter. Absolutely normal glucose, target glucose levels are attained, and the HbA1c is 7.4 after 16 weeks, and weight is 73 kilograms. So near the targeted, the glycemic control by around 2 months to be deemed fit for his cataract surgery. Coming to the summary, the major meal concept, the carbohydrate heavy meals, the initiation of the IDA class, initiate with 10 units once a day with the major meal, and twice a day dose splitting depends on meal size and postprandial glucose response should be considered. Switching from other insulin regimens, switch from pre-mixed basal and basal in 1:1 ratio, and dose reduction is seen in those who are experiencing hypoglycemia and HbA1c is less than 8%, and who are previously on IGLAR U300 experiencing hypoglycemia. So the dose reduction, in those cases, dose reductions are required. And perioperative use, it can be used in minor surgery at most safe. So thank you so much for your patient listening.